Hi everybody, and welcome to our module on acid-base principles. So the key to understanding all acid-base problems as a medical student is to know the acid-base equilibrium equation, which I've drawn on this slide here. Inside human plasma you can find CO2 and you can also find water, and these two molecules are constantly mixing together to form bicarbonate and hydrogen atoms. At the same time, the bicarbonate and hydrogen atoms are constantly mixing together to form CO2 and water. So this equilibrium is going back and forth all the time, and the body wants to maintain a very tight concentration of H plus atoms because it's the H plus atoms that determine the pH. The body needs the pH at a set level because if the pH is too high or too low, the proteins in the body won't work and the cells in the body won't work. So it's very important to tightly control this H plus level. And the way it does is by manipulating this equation. In addition to the equation, the next thing you need to know is that the level of bicarbonate is maintained by the kidneys and metabolism. The CO2 levels are maintained by the lungs, so you can get a high or low CO2 level if the lungs aren't working. So as I said, to understand acid-base disorders, you simply need to remember this equation. If you get a low level of bicarbonate in the bloodstream for any reason, it will drive this equilibrium in this direction, and that will tend to make more H+, which means you'll become acidotic. And that's what I've written up here. A low value of bicarbonate leads to a high H+ concentration and therefore a low pH. That's an acidotic problem. If you have a high level of bicarbonate, you will drive the equilibrium this way, and there will be less H+, and you will become alkalotic. By the same logic, let's focus on the CO2 now. If you have a low value of CO2, it will tend to drive the equilibrium this way and lower the H+ concentration and make you alkalotic. That's a high pH. On the other hand, if you have a high value of CO2, it will drive the equilibrium in this direction and make a high concentration of H+ atoms, and this will make you have a low pH and be acidotic. So make sure you understand what I just said about this slide. This is the key to understanding all acid-base disorders, is to understand the effects of high or low CO2 and high or low bicarb on this equilibrium, and therefore the effects on the H+ concentration and the pH. So this is the Henderson-Hasselbalch equation, which can be used to calculate the pH, but you're rarely asked to actually calculate the pH, and all this equation does is tell you what I just told you on the last slide. If the bicarbonate concentration goes up, that will raise the pH by this equation. If the bicarbonate concentration goes down, that will lower the pH. Similarly, if the partial pressure of CO2 goes up, that will lower the pH by this equation. And if the partial pressure of CO2 goes down, that will raise the pH by this equation. There are three blood measurements we perform to determine the status of a patient's acid-base equilibrium, and those are measurement of the bicarbonate level, the partial pressure of carbon dioxide, and the pH. Now normally when we take a blood sample from a patient, we take it from the venous system. This is a picture of someone having blood drawn from their antecubital fossa. This is a sample of blood taken from the venous system. This is what we normally do for most plasma measurements. However, to determine acid-base status, we need to take a sample from the arterial system, and for that reason we usually put a needle in the radial artery. This is called performing an arterial blood gas sampling. The reason we need a sample from the arterial side is because we need to know the CO2 level before blood has gone through the tissues and metabolism has occurred. So from an arterial blood gas sample, we can measure the bicarbonate level, the partial pressure of carbon dioxide, and the pH, and that will tell us the patient's acid-base status. On the screen here, I've shown the normal levels for each of these measurements. A normal bicarb is about 24, a normal PCO2 is about 40, and a normal pH is about 735 to 745. So let's talk about a few word definitions that you need to know. So an acidosis or an alkalosis is a medical condition that alters the hydrogen levels. Acidemia or alkalemia means you have a high or low pH in the bloodstream. So you can have an acidosis without acidemia if you have a mixed disorder. So for example, if the lungs are trying to create an acidotic problem, then the lungs have an acidosis. But if that mixes with a metabolic problem that gives you a normal pH, then you do not have acidemia. So make sure you understand the difference between those terms. So let's talk about the symptoms you might see in a patient who has an acidosis. The first thing you would notice is hyperventilation. This is called Kussmaul's breathing. So what's happening is the brain is recognizing the acidic bloodstream and it is trying to react by blowing off CO2. Let's look at our equilibrium equation down here. So if you decrease the CO2 level, you drive the equation this way and you lower the H+ concentration. So that's what the brain is trying to do by telling a patient whose H+ concentration is too high, meaning they're acidotic. It's telling them to hyperventilate to try and drive the equation this way and bring that H+ concentration down. Patients who are acidotic have depression of myocardial contractility. They can drop their cardiac output. The brain is very sensitive to the pH balance in the body. When you become acidotic, you get cerebral vasodilation, and you have increased cerebral blood flow, and you can get a high pressure inside the brain. If you have acidosis from high levels of CO2, you can get CNS depression. High levels of CO2 are a narcotic, and an easy way to remember this is that hundreds of years ago, pneumonia was called the old man's friend, because when they caught pneumonia, their CO2 levels would rise and they would start to get sleepy and lethargic, and then they would die, but it would be a painless death. And that's always what helps me remember that CO2 is a narcotic and it can cause CNS depression. Whenever you're acidotic, you can get hyperkalemic because high levels of H plus shift into cells in exchange for potassium, and therefore you get hyperkalemic. And then the last thing that happens when you're acidotic is you shift the oxyhemoglobin dissociation curve. This is called the Bohr effect, and lowering pH leads to hemoglobin releasing more oxygen. The easiest way to understand the Bohr effect is to draw a curve. So if we draw a curve with oxygen concentration down here on the x-axis and the saturation of hemoglobin up here on the y-axis, we find that there's a relationship between these two things that looks something like this. When you become acidotic, you shift this curve to the right so that you get a new curve like this. So what's going to happen here is for any given O2 level, there will be less saturation of hemoglobin than there would be if you were on the normal curve. And the reason for this change is because those H plus atoms tend to push oxygen off of hemoglobin. So the result is that oxygen more easily leaves the hemoglobin, and the hemoglobin is less saturated at a given oxygen level if you're in an acidotic environment. That's called the Bohr effect, and make sure you understand that. Now let's talk about symptoms of patients who are alkalotic. So they get inhibition of their respiratory drive. This is the reverse of the mechanism we described for acidosis. The brain wants the body to retain CO2 so that it will increase the hydrogen atom concentration and bring the pH back down into normal range. Alkalosis, just like acidosis, can cause depression of myocardial contractility, and then you get cerebral vasoconstriction when you're alkalotic, and you get a decrease in cerebral blood flow. Alkalosis can cause hypokalemia because it shifts potassium into cells, and then you get the reverse of acidosis. You shift the oxygen hemoglobin dissociation curve to the left in this direction when you are alkalotic. So what you need to learn how to do when you're a medical student is how to solve acid-base problems. And in these problems, they are going to give you the pH and the bicarbonate concentration and the PCO2 level and ask you what is the disorder. Now in the second module on acid-base disorders, I'll discuss specific acid-base problems and what causes them. What I'm going to do here is describe the general approach to resolving an acid-base problem. So the first step when you're faced with an acid-base problem is to check the pH. If the pH is less than 7.35, then you have an acidosis. If the pH is over 7.45, you have an alkalosis. The next step after that is to check the bicarbonate and PCO2 levels. Remember, you get the bicarbonate from the venipuncture, and normal is 22 to 28, but it's easiest to just remember it as 24 being normal. And you get the PCO2 from an arterial blood gas, which is called an ABG, and normal is 35 to 45. Most people just remember 40. Once you know the pH and the bicarbonate concentration and the PCO2, you need to determine the acid-base disorder. So if you have acidosis and a low bicarbonate concentration, that's called a metabolic acidosis. So let's look down at our equilibrium equation here. Remember, this tells you everything you need to know. So if the bicarbonate concentration is low, that will drive the equation this way and raise the concentration of H plus atoms, and that will cause the pH to fall and give you an acidosis. And when the bicarbonate is responsible for the acidosis, we call it a metabolic acidosis. If you have an acidosis and a high PCO2, that's called a respiratory acidosis. So again, we look at our equation. If the PCO2 level is high, it will drive the equation this way and create more H plus ions. That will lower the pH and give you an acidosis. So acidosis and alkalosis problems that come from the carbon dioxide level are called respiratory. If you have an alkalosis and a high HCO3, that's a metabolic alkalosis. And if you have an alkalosis and a low PCO2, that's a respiratory alkalosis. And all this is very easy to make sense of if you just remember this equation down here at the bottom of the screen. So once you've done all those things, you know whether it's a respiratory or metabolic problem, and you know whether it's an acidosis or an alkalosis, but there's still two more steps. For metabolic acidosis only, you have to calculate the anion gap. We'll talk more about this later, but the anion gap splits the disorders into two distinct groups of potential causes. And then the last thing you need to do is use special formulas to check for mixed disorders. So what's a mixed disorder? You can have a respiratory acidosis and a metabolic alkalosis at the same time. That's a combined respiratory metabolic problem. You can also have two metabolic disorders, so you can have a metabolic acidosis and a metabolic alkalosis. And the way you're going to pick these up is to use these special formulas to make sure the numbers you're seeing all add up. We're going to talk more about all of that in a minute. So if you want to make it even simpler for yourself to approach acid-base problems, just think of it in two steps. Step one is to determine what the acid-base disorder is. Is it a metabolic acidosis, a respiratory alkalosis, etc.? And then step two is to check for a second disorder. And the way you check for a second disorder is to determine whether or not the compensation is appropriate. So let's talk about compensatory changes. When you have a low bicarbonate level, that gives you a metabolic acidosis. And the body tries to compensate by lowering the PCO2, by hyperventilating. So let's look down at our equation right here. If you have a low bicarbonate level, it drives this equilibrium this way and creates more H plus ions, which makes you acidotic. The body will try to reverse that by lowering the CO2 level and driving the equation back in the other direction. If you just remember this equilibrium, you can make sense of all these compensatory changes. When the bicarbonate level gets high, that gives you a metabolic alkalosis, and the compensation is to retain CO2. That's hypoventilation. When the PCO2 level gets high, that gives you a respiratory acidosis, and the compensation is to increase the bicarbonate level in the plasma. This compensation is done by the kidneys. And when the PCO2 falls, this gives you a respiratory alkalosis, and the compensation is to lower the bicarbonate level by excreting more bicarb in the kidneys. In most acid-base problems you're going to face, the bicarbonate and the PCO2 are both abnormal. One of these is the culprit causing the disorder, and the other one is the compensatory change. And you need to be able to figure out which one is the cause and which one is the compensation. So the best way to do that is to go through a couple of examples. Consider a patient whose pH is 7.3. That patient is acidotic, and they have a low bicarbonate level and a low PCO2 level. Well, this patient has a metabolic acidosis with respiratory compensation. How do I know that? Because of these two changes, a low bicarbonate and a low CO2, only a low bicarbonate will drive the equation this way and give you an acidosis. Therefore, the low bicarbonate must be causing the problem. The low CO2 is driving the equation back in this direction and trying to fix the acidosis, so that's the compensatory change by the body. Here's another example where the pH is 7.3. It's an acidosis, but this time the bicarb is high and the PCO2 is high. So this must be a respiratory acidosis with metabolic compensation. And the way I know that is because they have a high CO2 and a high bicarbonate. Only the high CO2 will drive the equation this way and give you an acidosis. Therefore, that must be the cause of the disorder, a respiratory acidosis. The high bicarbonate is trying to drive this equilibrium back the other way and fix the problem, so that's the compensation. Make sure you can understand how to tell cause from compensation. So we need to understand these compensatory changes in a little bit more detail. So let's talk about respiratory compensation first. Respiratory compensation is always hyper or hypoventilation, and this will change the PCO2 to compensate for metabolic disorders where the bicarbonate level is abnormal. So with hyperventilation, the lungs will blow off CO2, the plasma CO2 levels will fall, there'll be less H plus in the blood, and the pH will rise. And this all makes easy sense if you just remember this equation. When the CO2 level falls from hyperventilation, it drives the equation this way, and that will tend to lower the H plus concentration. Hypoventilation does the reverse. The lungs will retain CO2, the plasma CO2 level will rise, there'll be more H plus in the blood, and the pH will fall. Renal compensation is a bit more complicated. When you have an acidosis, excess H plus gets filtered and secreted into the lumen of the nephron. And then two important changes are going to occur to compensate for this. The first change is fairly straightforward to understand. More bicarbonate is going to be reabsorbed in the proximal tubule. The second change is less obvious, but urinary buffers are going to be excreted. So these are things like phosphate and ammonia, and they can pick up H plus ions. That's why they're called buffers. And these prevent severe drops in the urinary pH. If you didn't have these buffers, the pH in the urine would get so low in the setting of acidosis that it would kill the cells of the kidney. But because you have phosphate and ammonia, these can pick up the H plus ions and prevent the pH from getting that low. So it's very high yield to know for your boards that in the setting of acidosis, the bicarbonate reabsorption goes up and the excretion of urinary buffers goes up. When you have an alkalosis, the reverse occurs of all the changes that happen with acidosis. So now that we understand how the body compensates for a respiratory or metabolic acid-base problem, let's talk about how we recognize mixed disorders. So a mixed disorder is two acid-base disorders at the same time. You can have a metabolic acidosis and a respiratory problem, or you can have two different metabolic problems, like a metabolic acidosis and a metabolic alkalosis, or two metabolic acidoses. And there are many pathologic states where two disorders occur at the same time. One easy example to understand is vomiting and diarrhea with GI illnesses. The vomiting tends to make you alkalotic and the diarrhea tends to make you acidotic. So to uncover the mixed disorder, you need to determine the expected compensatory response. So for example, you can determine the expected bicarbonate response for a respiratory disorder or the expected CO2 for a metabolic disorder. And there are a number of renal formulas that will help you determine the expected response. And then if the actual doesn't equal the expected, you've got a second disorder present. And this is how you uncover mixed disorders in an acid-base problem. One thing that's extremely useful to know is that the body cannot compensate to a normal pH. So suppose, for example, you had a pH of 7.2, that's an acidosis. The body might be able to compensate and raise this back up to 7.3, but that still would be acidotic. If you saw a pH of 7.4, which is a normal pH, then there must be a mixed disorder because compensation alone cannot raise the pH all the way back to the normal range. So a classic scenario is to see a normal pH when the bicarb and CO2 are both abnormal. Right away you know there must be a mixed disorder in order for the pH to be in the normal range. So getting back to recognition of mixed disorders, if the actual compensation is different than the expected, then you must have a mixed disorder, and the next step is to determine the abnormality. So for example, if the CO2 is higher than expected, then you must have a secondary respiratory abnormality causing the CO2 to be abnormal. If the bicarbonate level is lower than expected, then you must have a secondary metabolic disorder affecting the bicarbonate. And the usual rules apply for determining the secondary disorders. A high CO2 is some type of acidosis, a low CO2 is an alkalosis, a low bicarb is an acidosis, and a high bicarb is an alkalosis. So now let's talk about the specific compensation formulas that you can use to get a number for what your expected compensation is. Of these, the most important is Winner's formula. This is the one that's most commonly tested on step 1. Then there are other formulas for metabolic alkalosis and for acute and chronic respiratory acidosis. And finally, there's something called the delta-delta, which we'll talk about in another module for anion gap acidosis problems. So if you have any kind of metabolic acidosis, it doesn't matter whether it has an anion gap or not, the compensation is a respiratory alkalosis of lowering the PCO2, and this occurs from hyperventilation. And Winner's formula is what tells you the expected PCO2. If the actual CO2 doesn't equal the expected, then it's a mixed disorder. And Winner's formula is 1.5 times the bicarb concentration plus 8 plus or minus 2. And the easiest way to understand this is to use it in a couple of examples. So suppose you have a pH of 7.2 and that's an acidosis, and the bicarbonate level is 9. That's low. The normal bicarbonate level is 24, so this is a metabolic acidosis. And the PCO2 is 22. That's also low. Normal is 40. So if we plug these numbers into Winner's formula, the expected PCO2 is 1.5 times 9 plus 8, which equals 22 plus or minus 2. So we should have a PCO2 anywhere between 20 and 24, and we do. Our PCO2 is 22. So this means there is no secondary disorder. This is a simple metabolic acidosis with nothing else going on. Winner's formula has helped us to figure that out. Now let's take another example. Suppose the pH is 7.28, so this is an acidosis. The bicarbonate level is 12, so that's low because normal is 24, so this is a metabolic acidosis. And then you have a PCO2 of 40 and normal is 40. So right away I know there are two disorders here because the PCO2 is normal. The PCO2 should never be normal in the setting of a metabolic acidosis. Respiratory compensation is very quick and the body will quickly lower the PCO2 to compensate. So I already know there's a problem before I've used any formulas. But for completeness sake, we're going to employ Winner's formula, and the expected PCO2 is 1.5 times 12 plus 8, which is 26 plus or minus 2. So the PCO2, according to Winner's formula, should be somewhere between 24 and 28, and it's not. The PCO2 is too high. It's greater than expected, and this means there is a concomitant respiratory acidosis. And like I said, you can figure this out through the formula, but you actually know it right away because you have a normal PCO2 in the setting of an acidosis. So now let's talk about the compensation for a metabolic alkalosis. The compensatory response is to create a respiratory acidosis to raise the PCO2, and that happens through hypoventilation. And there is a rule of thumb that the PCO2 will rise 0.7 for every 1 milliequivalent rise in the bicarb. And if your actual PCO2 does not equal your expected, then you have a mixed disorder. And I've written the equation for metabolic alkalosis compensation down here. The change in PCO2 is 0.7 times the change in bicarb. So this is easier to understand if we do an example. Suppose the pH is 7.5. That would give us an alkalosis. The bicarb is 34, which is increased because normal is 24, so this is a metabolic alkalosis. The PCO2 is also increased at 47. It's higher than normal at 40. So we're going to try to determine if this compensation is appropriate. So the change in bicarb is the patient's bicarb of 34 minus a normal bicarb of 24, and that's 10. So the expected change in PCO2 is 0.7 times 10, or 7. Then the actual change in PCO2 is 47, the patient's PCO2, minus a normal of 40, and that's also 7. So because the expected change and the actual change are equal, there is no secondary disorder. And this is a way you use this compensation rule of thumb here to check to make sure the compensation for metabolic alkalosis is appropriate. The compensation for a respiratory acidosis is different depending on whether the respiratory acidosis is acute or chronic. So within minutes of developing a respiratory acidosis, intracellular buffers will soak up some of those H+ protons and raise the concentration of HCO3. These buffers are things like hemoglobin and other proteins. This will result in a small rise in pH to compensate for the acidosis. But chronically, after several days, the kidneys will generate more bicarbonate, and this will result in a large increase in pH. But remember, not back to normal. You can never compensate all the way back to a normal pH. So there are different equations for determining the expected compensation for acute and chronic respiratory acidoses. Frankly, these equations are fairly low yield, and I wouldn't worry about memorizing them. I would just know that they exist. Once you know Winner's formula and many other things about acid base, you can come back and memorize these if you wish. Acutely, in a respiratory acidosis, there's a small amount of compensation. There's a 1 milliequivalent rise in bicarb for every 10 millimeter increase in PCO2. And if you want to turn that into an equation, the equation is the delta HCO3 is equal to the change in PCO2 divided by 10. Chronically, there's more compensation. You get a 3.5 milliequivalent rise in bicarb for every 10 millimeter increase in PCO2. And it's easiest to understand this by way of an example. So let's suppose we had a patient with a pH of 7.15. That would be a very severe acidosis. And let's suppose the PCO2 is 80. That's very high, and that makes this a respiratory acidosis. Acutely, the change in bicarb would be 40 divided by 10 by the equations above, and that would be a very small change of 4. This would raise the bicarb from a normal of 24 up to 28, and by the Henderson-Hasselbalch equation, the pH would become 7.17. Chronically, we'd get more change in bicarb. We'd get a rise of 3.5 times 40 over 10, or 14. This would take the bicarb from 24 all the way up to 38, and therefore by the Henderson-Hasselbalch equation, the pH would go all the way up to 7.30, so it would be getting closer to normal. Just like for respiratory acidosis, in respiratory alkalosis there are different formulas for the acute compensation and the chronic compensation. So in an acute respiratory alkalosis, you get a small amount of acute compensation. You get a 2 milliequivalent fall in bicarb for every 10 millimeter drop in PCO2. Chronically, you get more compensation. There's a 4 milliequivalent fall for every 10 millimeter drop in PCO2. And it's easiest to understand this with an example. So let's suppose you had a pH of 7.65. That would be an alkalosis, and let's suppose that the PCO2 was 20, that's low, and that makes this a respiratory alkalosis. And this is like what happens to people when they ascend to high altitude. They hyperventilate to maintain oxygen, and they develop a respiratory alkalosis. Acutely, there'll be a very small change in bicarbonate. It'll be 2 times 20 divided by 10 by the equations above, and that's a 4 milliequivalent change. So the bicarb would drop from a normal of 24 down to 20, and by the Henderson-Hasselbalch equation, this gives you a pH of 7.63, so still pretty alkalotic. Chronically, however, the change in bicarb would be greater. It would be 4 times 20 divided by 10, or 8. This means the bicarb is going to fall from 24 down to 16, and this gives you a pH that's closer to normal of 7.53. And this is what people who live in high altitude look like chronically. After a while, their body begins to adjust, and the kidneys excrete bicarb, and they have a very low bicarbonate level, and their pH falls back towards normal, although remember, you can never compensate completely back to the normal range. A word on the time frame of compensation. Respiratory compensation to metabolic disorders is very rapid. The change in respiratory rate is quick and it's within minutes. The metabolic compensation to respiratory disorders is much slower. Acutely, you get that very small compensation from cells, but the chronic compensation, which is the more significant component, takes days to materialize. So let me finish with this slide, which is a summary of the different compensations for acidosis and alkalosis. So if you have an acidosis, it can be either respiratory or metabolic. If you have a respiratory acidosis, the compensation is to raise the bicarbonate level, and there are formulas, rules of thumb, for acute and chronic changes to the bicarbonate level to determine if the compensation is appropriate. For a metabolic acidosis, the compensation is to lower the PCO2, and you can determine whether the compensation is appropriate by Winter's formula. And remember, of all these formulas, Winter's formula is the one that's most commonly tested on step 1, and it's the one you should definitely make sure you have memorized. If you have an alkalosis, it can be either respiratory or metabolic. If it's respiratory, the compensation is to alter the level of bicarbonate in the blood, and there are acute and chronic formulas for this. If it's a metabolic acidosis, the compensation is to raise the PCO2, and there's that rule of thumb for the expected PCO2 that you can determine. So this concludes our first module on acid-base disorders. In this module, I've explained how to determine the compensation and whether it's appropriate. In the second module, I'm going to talk about specific causes of acid-base disorders and how to recognize them.